Welcome to The Pink Underside, Women, Men and Hereditary Cancer, a podcast from Dr. Sharlene Hesse-Biber. In our first episode, Dr. Hesse-Biber talks to me, Chris Garrington, about her recent research on women who've tested positive for the breast cancer or so-called BRCA gene mutation and the decisions they make after finding out they have it.
In 2014, I wrote a book called Waiting for Cancer to Come, a study of the lived experience of women who actually tested for inherited breast and or ovarian cancer and what that was like for them, why they decided to get tested, and what kinds of decisions did they make after that. And this particular research project is part of that, but it's really analyzing surveys on a range of women beyond the 60 women I interviewed, the in-depth interviews I did, asking a wider group of women the same kinds of things, but asking them in a way that's much more closed-ended questions rather than listening deeply.
So what did you want to look at here very specifically, and why?
Breast cancer is the second leading cause of death among women, and about 5 to 10% of these breast cancers are inherited genetic mutations. We all have BRCA genes, BRCA1 and BRCA2, but when they mutate, they can place women at a much higher risk for developing breast cancer over the course of their lifetime. BRCA1 has a 57% lifetime risk of developing breast cancer, while someone that gets the other gene, BRCA2, has an increased 49% risk. I wanted to see how a range of women make decisions about getting tested and wanted to really examine traditional views about why women do this. This idea that once women know their risk, they'll do whatever the doctors tell them to do. The doctors will manage their care, will decide if they need to get surgery, and so on. And in my own research, I posit a very different view of how this is done. Listening to women's lives, you find out very quickly that they don't make decisions the way the doctors think they do.
Tell us a bit more about what you mean by that, Sharlene.
They have this medical model of decision making, that the women will go about making decisions by adhering to whatever it is their care provider tells them to do. And there's this praise of expert knowledge, and of course women are going to make these rational decisions. Well, if I learned anything from the 2014 Waiting for Cancer to Come book, is that women don't make decisions that way. And what I wanted to do was to get more hard facts about how they specifically do this across a wider spectrum than the 60 women I've listened intently to. So I decided to combine my in-depth interviews with 60 women, with many women I could get online who would take my survey. And I went to many, many websites that are support groups for women with hereditary cancer. And slowly but surely, I began to get a spectrum of women.
So let's talk a bit about that online survey now, Sharlene. How did it work, and what sorts of things were these women asked about?
I wanted to really look at the whole, what I call nexus of decision making beyond this kind of rational expert model that these doctors were thinking women were basically operating under in making decisions. To look at how they do this more quantitatively, using numbers rather than only words, to really create a sort of model of decision making, how it happens in a more quantitative way. So I wanted to tell in this article a quantitative story.
So tell us something about the sort of information you collected from people.
I wanted to look at demographics, their age, the number of children, whether they were married or not. Wanted to look at their families, cancer history, and I wanted to look at some psychosocial factors, how distressed they felt, how vulnerable they felt, how much they felt they lost control of their lives, and how this too might have impacted their decision-making process, from getting tested, deciding to get tested, whether or not they should get surgery, and how soon.
What emerged that really caught your eye?
What the main conclusions are is that women make decisions based on family factors, whether or not they have children, whether they have daughters or sons, how supportive their family is, especially their husband, how involved these women are with their BRCA positive diagnosis. Do they go online a lot? Do they talk to doctors? Are they involved with this disease to a great extent? And also, psychologically, how distressed they feel, how much at risk they feel. So putting together all of these things was really an amazing set of findings for me that really flew in the face of this kind of rational model. And so what I want to do is sort of take you through how all of these social psychological factors and other factors really intervened in the way they thought about getting tested, how soon, and whether or not they decided to go for surgery and how quickly.
So when it came to the age at which women in your study got tested for the BRCA gene, what did you find there?
The first thing was that the age of testing for the BRCA mutation was, as I mentioned, related to family factors, such as whether or not one received social support, how involved women were with their BRCA mutation 6 months before they were tested, whether or not they had children. And more sort of an unanticipated finding was whether or not their mothers had a breast cancer history and how soon in that history was she diagnosed for cancer, for the BRCA mutation. And so what I found is that if the mother had a history, an early history of cancer, BRCA breast cancer, she would test, the daughter would test sooner rather than later. So that the later the mother's cancer diagnosis, the later the daughter's. But if the mother's cancer diagnosis was early, she got tested early, sometimes on her birthday, her mother's birthday. And they're very likely to do it more or less the same age as their mother was tested.
So what did you make of what was going on there?
So I thought that these women actually were following their mother's cancer clock. And when that clock was close to the age that, say, their mother died from the BRCA mutation, they would get tested very quickly. What I also found is that when women did not feel they got the social support from their significant others within their family, they got tested later. They didn't have that support to go for it. They felt somewhat isolated, somewhat concerned, but it didn't propel them to want to know what they thought might be bad news. I found that the more involved women were with worrying about the BRCA mutation, 6 months they were tested, they spent time talking to their doctors a lot, going online and reading about this, the more likely they'd get tested sooner than later.
Where a woman went on to have preventive surgery, were there any factors that seemed to be influential there?
Once they tested positive, there were many joint influences that came together around the following kinds of factors. The influence of family factors, social psychological factors, and again, BRCA involvement that really pushed them into surgery rather than staying in surveillance. So to be more specific, women without children were more likely to have preventative surgery instead of surveillance. And women with daughters were more likely to have surgery than those only with sons, which I thought was really interesting because I think involved in, even within a situation where women are very cognizant of this BRCA mutation, some of them still felt their sons couldn't get the BRCA mutation. It wouldn't be inherited. And this is kind of a myth that flows within the wider population. Men can't get breast cancer. Of course, if I have the BRCA mutation, I have to worry about my daughters, not my sons. And it's interesting that you're equally likely, if you have a BRCA mutation, to give it to your daughter as well as your son. But this has not filtered down very much within the BRCA community. And it's something that will be a subject of another podcast that I will be doing on when you inherit the gene from your mother versus your father and what impact that has on your future cancer diagnosis.
So what sorts of psychological and social factors were at play in terms of driving a woman to actually act on her diagnosis?
The more distress experienced toward the BRCA results and the more medical uncertainty women said they experienced with regard to whether or not they had a supportive family person at their side, the less likely that they would take any action to have surgery. On the contrary, the guiltier a woman felt about passing the gene on to her children, the more likely she would have surgery rather than staying in surveillance. And again, BRCA involvement 6 months after getting tested, the more involved one was, the more likely that this woman would have surgery over surveillance.
Now, you asked participants to think of their lives as a pie chart and to indicate the proportion of their life that they felt was affected by BRCA. What did that show?
The more involved these women were 6 months after the test, the more likely they were to have surgery earlier, and they were really pushed into surgery rather than staying in surveillance. So BRCA really made them think more about the impact it had on their life and propelling them to get tested earlier, to have surgery, and to have surgery earlier. So BRCA involvement plays a big role in fueling concern about this genetic disorder.
What did you make of your findings overall from this particular piece of research, Sharlene?
This article was part of a journal of genetic testing, and I really wanted to get the message out to genetic testing folks, especially counselors and medical professionals, that genetic advice, when you're giving it, needs to be filtered through a kind of lens that takes into account women's specific social, psychological, and demographic factors. Not all women are the same. That this information impacts women differently depending upon a set of other factors that they may differ on. So we need to take into account the kind of particular standpoint women bring to this bad news, because it can impact what they hear and what they do, how soon they get surgery, whether or not they get surgery. These are all important things, so that we really need to reframe this kind of medical model of statistical risk through this kind of nexus lens of decision making that includes women's social networks, their families, psychosocial factors that can drive these decisions, such as feelings of guilt, feelings of vulnerability, their perceived social support among their family, especially if they're married, their spouse. For example, women who felt guilty, we mentioned, don't want to give this gene to their children. And those women also who feel their sons can't get cancer, places maybe their sons at risk. So I think this decision-making nexus is an important part to take into account when we are sitting with a BRCA-positive woman who is trying to understand, what do I do next?
And what about for women themselves, Sharlene? Is there a message for them here, do you think?
I think first and foremost, it's really hard for women to take in when they're sitting in the genetics counselor's office just what the numbers mean. They're told their risk of developing breast and/or ovarian cancer is X%, and it sounds like they're going to die tomorrow. As one woman said to me, I felt that my breasts were ticking time bombs. I couldn't wait to get out of the office and get my surgery done. And very often, I think what women don't realize is that risk is over the course of their lifetime. Doesn't mean they're going to get cancer tomorrow. And so rushing into surgery without really taking the time to decide, when it's appropriate, and also looking at your own psychosocial concerns. Maybe your husband isn't supportive. Maybe you need to reach out to other members of your family to make that surgical route supportive for you to continue on your journey. This brings up a lot of intervention issues that counselors also need to think about, and asking questions. Do you have family that can support you through this? What are the resources that you need? Not all women need the same thing. So what I think is for women to realize that cancer risk, one size does not fit all, and that for genetics counselors to really look at women's decision making in a much more holistic way, as we have concluded from this article.
Genetic testing and post-testing decision-making among BRCA-positive mutation women, a psychosocial approach, is researched by Sharlene Hesse-Biber and Shen An and is published in the Journal of Genetic Counselling. More information is available at www.hessebiber.com.